Okay, so we can start. Good afternoon, everyone, and thank you for joining us. This is the day 3 of our IRC web series on the ongoing challenge of COVID-19, a toolkit for respiratory care management. Today is the last day where we will uh, look at the post, ventilator, or the aspects that need to be looked at while the patient is undergoing treatment, as well as after that. We will also look at managing COVID in children. So thank you for joining us. We will begin without any further delay. Our first session for today is by Mr. Ashish Yadav. He is a respiratory therapist at SL Raheja Hospital, Mumbai. He has been on the COVID forefront, as a COVID warrior, managing COVID patients since day one that it has been in the country. And thank you, Ashish, for joining us today. He's going to talk to us about pulmonary rehabilitation in COVID-19 patients. And over to you, Ashish. If you all have any questions for him, please feel free to ask them in the YouTube chat box that you see. Or you can, if you've joined us in the Zoom session, please feel free to put it in the Zoom chat box. Thank you. Over to you, Ashish.
Thank you, ma'am. Thank you so much. Good evening to all. I'm Ashish Yadav, and we'll be starting our session on pulmonary rehabilitation. So, first, just a second. Yeah. So, basically, today's our topic is pulmonary rehabilitation just in the ICU. We'll talk all about the pulmonary rehab in the ICU. We are seeing this pandemic and rise of COVID since first wave, second wave, and third wave. The way we are seeing and dealing the patient is very, very difficult for us to wean those patients out. And how does a pulmonary rehabilitation is going to help us in weaning those patients? And even after we've been saying that the most of the patients who have been intubated, the mortality rate of the patients who have been intubated is very, very high. We already know that. So is there any change or challenge, and is there any technique others that includes in the weaning part of the mechanically ventilated patients or severely ill patients, which includes severe, mild, moderate, and severe? So we'll be looking after that part first. So let's start. What is the pulmonary rehabilitation? So the pulmonary rehabilitation. So pulmonary rehabilitation is basically defined as a multidisciplinary intervention based on personalized evaluation, which is very, very important. If you don't look after into this aspect, you won't be able to manage some patient easily. As we can't just go into and look into the books. Practicality changes very, very differently. So the personalized evaluation and treatment, which includes but does not limit it to exercise training, education, behavior modification is designed to improve physical, psychological condition of the people with respiratory disease. So rehabilitation is nothing but we just want our patient, we can't change the condition right now, but we can make sure that in that condition itself, can a patient go home or can he do his day-to-day life? Okay, so rehabilitation. Let's talk about who are the people who can perform pulmonary rehabilitation in the ICU. So first of all, earlier we have seen physiotherapists. They just come in, they give physio, chest percussion, vibration therapies. They'll do some breathing exercises and they'll leave. But the reason behind who would be an ideal candidate or who would be a master to do a pulmonary rehab in the ICU is no one but a respiratory therapist. So we have to give this and take a role to us. So let's just keep calm and let a respiratory therapist handle this situation. Why? Because he is the one who also knows the clinically in and out of the patient. He also knows the mechanical ventilatory strategy which is going on from day one to day out of the patient. So I'll say RT is the best person to do a pulmonary rehab in the ICU. So what are the benefits, as I say? So the benefits of pulmonary rehabilitation is very, very dramatic, and there is a completely damaged lung. We are just charging up the lungs power. We want the lungs to get better, but will it get better completely to the 100%? No, it is not that pulmonary rehabilitation may make your patient stand up and run within a day or two. It takes time, so we have to give the time to the patients. So let's just understand what would be the goals of the pulmonary rehab. So first goal is, what will the pulmonary rehabilitation? It will reduce the work of breathing of the patient. So it is by performing the rehabilitation, it will reduce the secretion, retention, atelectasis, chances of pneumonia. It will relieve anxiety. And most important is improves the quality of life and reduce further complications. What are the major clinical impact which will change, and what would be the goals of rehabilitation? That is maintaining or recruiting the lung volume, because as in the COVID, we are seeing either the lungs are getting completely fibrous or it is getting completely consolidated with the downglassing opacities all over the lung. And if the high severity score of more than 20, it is very, very difficult for the patient even to stand up or even sit on the edge of the bed. So we want to recruit and maintain those, increase the lung FRC of the patient, and the most important, optimizing the ventilation and oxygenation of the patient. What it will more do, as the FRC of the patient improves, it also helps the patient to increase in compliance. It will reduce the ventilation perfusion mismatch, decreasing the ventilator dependency of the patient, and improving residual function. Improving, and we also have to look after because of the patient is so mechanically ventilated for long, around 15 to 20 days. So the respiratory muscle cells are drastically reduced. So we want that to come up so that the patient will be able to breathe and go home easily. So there are three major types of the patient which will look after in the ICU. So first is the acute phase. What is the acute phase? Acute phase is a very, very severe respiratory distress condition. So these are the patients which would be either intubated, or they would be on the helmet or NIV with the FR to 100%. You would be starting a dexamethasone fentanyl to stop the respiratory rate. It comes down the bed, reduce the tachypnea, or the patient would be prone for around 2 to 3 days. 3 to 4 cycles of proning has been given to the patient by mechanically ventilated, or the patient will be tracheostomy. So these patients are very, very severe, and these are the patients which you have to look after to, so that these are the patients you want the patients, such patients to come out. This is the major role, or the criteria, or we can say some of patients where we have to make sure our pulmonary rehabilitation works. So this is a difficult zone where we have to work into it. So what happens in acute phase, it's a airway clearance techniques we need to be recommended in this patient, and during the acute phase in this patient without major problems of the bronchial obstruction. So what would the ventilatory support, as the monitoring of the clinical conditions would be there, adjustment of the mechanical support and oxygen therapy would be going continuous, or of extubation protocol without NIV, re-intubation protocol. All this needs to be followed very, very drastically. And when the patient, while treating the patient of acute respiratory failure by weaning or NIV, the mechanical ventilation is recommended to use the similar protocol which we are already using it. artsnet.com has already given us the complete ARDS protocols to be used. So this is the complete scenario of acute phase. So acute phase patients will be very, very difficult. So before starting or ending to it, so which would be the patient? What should be the criteria before I even to start, or what should be the criteria I look into either to stop the rehabilitation? So we will see this by every single system. So if we go and see in the CVS, the cardiovascular system, so what would be the starting criteria? First, you have to look into the patient's heart rate is more than 40 and less than 120. Systolic blood pressure should be more than 90, less than 180. MAP should be maintaining at least about 665 and less than 110. And what are the things we need to look after? There's the most what the absence of new arrhythmias, myocardial ischemic shock with the lactic acidosis level, the new unstable DVT, pulmonary embolism, suspected aortic stenosis. So there are very less evidence to whether to perform the pulmonary rehab in the ICU in the deep vein thrombosis or the pulmonary embolism patient. So majorly we should avoid taking these patients for the pulmonary rehab. And so this would be a cardiovascular. So what happens? What happens when I look after when to stop? When to stop in the cardiovascular zone? Let's say so the heart rate is going less than 40 or more than 100. So it is basically a tachycardia or a bradycardia. The patient is going into severe hypotension or hypertension. The MAP should not go above more than 20. So basically, if there is a change in MAP more than 20%, you have to immediately stop from the baseline. So if you go and see while before the starting of the your session, you saw the MAP was around 70-75, and later you saw the now he started the session and the MAP is lost more than 20% from the baseline. So this could be a right time to stop the rehab and let the patient settle down first. Presence of new arrhythmia or myocardial ischemia. So now let's see what could be in the respiratory system. So first major goal, let the FiO2 come down. So the FiO2 should come below less than 60%, 0.6%. Make sure your FiO2 is less than 60% because of in patients with high FiO2 changes, giving up rehabilitation session could lead into severe respiratory failure again. Maintain the saturation of above 90%. If a patient is not maintaining a saturation more than 90, okay, so you should not start the session. And one of the criteria is PEEP should be at least 10 or less than 10. So the deterioration of PEEP has reached till less than 10. Absence, there is no vertical resistance, unsafe bleeding, airway problem, which could be mucus plug. The plateau pressures are high, or the patient is in the pneumothorax. We should not go into the patient when we start. So you should make sure the patient doesn't have a pneumothorax, that there's no hidden airway problem, no ventilatory resistance has been present. And what should be starting, as I said, the saturation should not be below 90%, so you should not start, or there is a decrease in 4% from the baseline of the SpO2 from the starting. So you should make sure your pulmonary rehabilitation is continuous monitoring, as I have said, which is a continuous monitoring while performing the session. Even a single moment, even a severe drop in 20% of blood pressure, tachycardia, bradycardia, or a drop in saturation, or a patient is going into severe tachypnea, which is more than 40, there is again no absence of ventilatory resistance. You find there is an absence of ventilatory, there is a clotting coming up during your sessions or a mucus plug, you have to immediately stop. Artificial airway dislodgement of the tube or the magnetic tube is come out, deterioration of chest X-ray, it's more than 50% within the 24 to 48 hours. So this is the absolute criteria where you should stop the pulmonary rehabilitation of the patient for a while. I am not saying that you have to stop it completely, but for a while you have to stop it. So, and our next system is CNS. In CNS, majorly we are going to see recommended agitation score scale, which would be +2, or your intracranial pressure would be low, as you can see. Now, how this is a very controversial question. How will I look into the intracranial pressure, how will I understand what is my ICP? So if your patient is intubated, your rise in PCO2, could also be a clear indication that your patient's intracranial pressure is rising. So this could be a one small thing to look after, or vital to look after, whether your patient intracranial pressure is rising or not. So, and change in consciousness with irritability, uh, you can also see if a patient is getting drowsy and very irritable, agitated. This is the point, or the patient could be also going in the IC psychosis. You should stop the rehab for a while. So what could be the other systems or other parameters or the other criteria we should also look after? We have already seen cardiovascular, respiratory, and CNS. So there is an absence of unstable limb or a spine fracture, severe underlying hepatic renal syndrome disease, or progressive worsening hepatic renal impairment, SGOT, SGPT. All these bilirubin level, ammonia has been continuously rising and haywired completely. We should continuously monitor and see all the investigations should be checked before starting or stopping. And is there any active hemorrhage? So there is any bleed, or a patient has a fever. So you have to look at the absence of all this in temperature, active hemorrhage. If there is no hepatic renal syndrome, no spinal fractures which has been present and not been treated yet, you have to look after. So this could be the absence of starting criteria you have to look after. So what could be the stopping criteria? Again, discontinuation of any treatment, removal of monitoring tube connected, which could be anything with respect to your lines, tube, tracheostomy, your central line, arterial line, which could be anything. So patient persists. So does the patient have a palpitation, any exacerbation episodes of dyspnea, shortness of breath, intolerable, completely fatigued? Now the patient is falling in because of so much of intolerance and respiratory fatigue. You have to stop it. So these are the major criteria. So you can look after this criteria into very severely in the acute phase of the patient, when mild, moderate, or the patient into the mild, moderate patient or a mild patient. So this is the absolute criteria. I'm not saying this could be the criteria which could also falls in the presence of the rehabilitation at home. There is different criteria for it, but for the mild, moderate, and severe, so this could be the maximum criteria and maximum things you have to look into it. So let's start with our therapy. So what does our therapy include? So now we have seen what is rehabilitation, who is the best person to perform the rehabilitation, what is the goals mentally, physically, and how it will clinically change the patient's life, and what else things you have to look after it. What could be the different criteria to stop and start the rehabilitation? And now we'll go what is the therapy basically we need to start into it. So rehabilitation COVID-19 mainly includes, first is your position management. Your position management plays a very vital role in the ICU. It's already been playing into the ICU from very long. Early mobilization and physical exercises. Your next is respiratory exercises, physical exercises. So we'll start with the position management. What all things come under the position management? Which position should be given? So your position management includes with the both apical. So first, to manage to the position management is your clinical skill. Basically, you have to look out with the imaging scans of the patient, the X-ray and the CT scans. Which part of the lung is being completely dependent or independent lung, you need to understand by that. So we need to go and see the both upper loop, apical segment, both anterior and lateral segment. So you need to make sure these are the various positions to how to open up, or the which lung of the which part of the lung will get opened up, or which will get drained out by your giving a certain position. So there are several positions you can see, both upper upper lobe, apical segment, you can see the proper position, which is more than 45 degrees, and less than 45 degrees, you can see the left lower lobe. Anterior segment would be opening up. There is a right upper lobe segment, then there is prone position with propped up of 45 degrees, which could open up the left lung of posterior segments. Then there is prone lateral upper lobe, inguinal, lower lobe, so superior segments, right middle lobe. So understanding and giving the position of the patient. The change of position is one of the things should be changed every 2 hourly in the ICU. It is not just because I need to open up the lungs. There is also something known as bed sores. So the prevention on management of the bed sore is also includes change in position in the ICU. So there is a simple chart we can say. We can start from at morning for 2 hours. That the patient should be right lateral. Then after 2 hours, left lateral. Then there is proning. Then supine. So moment the patient comes for the lunge, your patient is supine again in the proper position. So the patient can have his lunge, wait for half an hour again, and again go back to the same right lateral, left lateral, proning, and again proper position. And then again first after the 6 hours, the patient is back to his dinner time. So these 3 cycles play a very, very simple. Always make sure the patient is going into it. So now early mobilization and physical exercises. What does early mobilization basically does? Why there is need? So aggressive before performing, you need to understand that for early mobilization, you're aggressive monitoring, because if you're doing early mobilization of the patient, you can't go anywhere. You have to stand there with the patient, whether the patient is mobilized for half an hour, 45 minutes. You have to stand there with the patient, and if you want, you can do a chit chat with the patient, and you can have a deep conversation of your life and his life about it. So what aggressive monitoring is required to prevent tubing, disadvantage, vital signs should be monitored. So first thing is, what should be the intensity? Intensity of this should be lowest when durations or activity scope can be used in this patient for poor physical fitness, and patients only need to complete the movement. So which are these patients basically which can require such low intensity? So these are the patients who be ventilated on a mechanical ventilation or tracheostomies for very, very long, more than a week. Their respiratory muscle strength is reduced drastically. They don't have even energy to make sure they can lift up and sit at the edge of the bed. So even they can't even move. The limb exercises is a very, very difficult job. So these are the criteria of the patient plays into it. So how much should be the duration? Your duration training for a single session should not exist for more than 30 minutes, which include, that doesn't mean I have made my patient, I have DHR, and I just want to make sure my patient sits on the chair. So I want to, so here from the starting, from the minute you went to the patient, you started mobilizing him on bed itself, that is the time where you can count the time. So your entire session, including sitting and whatever you try to do, it should not exceed more than 30 minutes, because that can cause exacerbation of the fatigue and the patient may lather also land up into respiratory failure again. And all your work which you have been doing a hard work on the patient for more than 7 days would be gone bush within a minute. So you have to make sure that you should avoid these things. So what all things I'll look into my early mobilization. My early mobilization techniques is a very, very simple technique. First thing my technique started. First, I'll make sure I'll make a patient sit on the bed at the edge of the bed. So this is the first target. First, I'll make sure the patient sits on the edge of the bed. Then next is I'll see if the patient is moving out of the bed and sitting on the chair. So I have to make sure, even though, so this, when in India, or in India, most of the hospitals, we haven't seen, we only make sure the patient who sits on the chair, that could be who is not mechanically ventilated, who's not on an IV. We even are so scared if the patient is on an IV, we don't want the patient to sit on the chair. So this is a very, very bad myth we are going into. We have to also make sure the patient should sit on the chair even if the patient is mechanically ventilated or a patient is on still ventilated ACDC mode. That doesn't matter. So every day we have a small criteria which is performed everywhere in the ICU, which is known as SBT, which is spontaneous breathing trial. So that starts with a spontaneous awakening trial. You try and make sure your sedation and paralysis is off since the early morning at 5 o'clock, 4 o'clock. You make sure the patient is completely wide awake. The patient falls into your criteria. Now, in this patient, should I make? We are so scared if I take a patient who's already intubated on mechanical ventilator. Should I make sure the patient sits in the chair? Yes, you should. Yes, you should. How and what this will help to a mechanically ventilated? Can this patient go into a severe respiratory distress? Yes, they can go. But this is what you are there for. That is why RT is there for to look after those things. So you have to make, and how this will help? It will open up the functional residual capacity of the lung, and that will also help to open the compliance of the lung. So these are all the things, as it is already been said that weaning is an art. So if you are a master in the art, you have to look. So you have to get master, and your weaning just not go into the book and see RSBI and NIF and all those things. I also have to look at my mobilization, my basic goal in the weaning. I have to make sure the patient's lungs is open. So I'll try my best and do everything possible for it to do it. So now next step, so I have made sure that my patient is first. So if I started, how does my session go? First, I'll make sure my patient sits on the edge of the bed for a minute or two. Then I'll move my patient out of the chair. Once my patient is sitting on the chair, so this is my first step. And we have to make sure that I am not going to hurry these patients, not at all. So if I'm not going to hurry up, I don't want my patients to hurry up at all. This is COVID. This is not normal ICU or normal any pneumonia or non-cardiogenic ARDS anymore. This is COVID, of course. So you have to make sure you go very, very slow. And so first, so I'm done edging or move the bed. I'll make sure I'm making every single day, making every early morning I go on my rounds. I'm making my patient sits on the chair. I'm happy with it. So my next step would be, let's make the patient to stand up. So first he'll stand up. He'll shake. He'll require the support. 2 to 3 people, doesn't matter. So I am making the patient stand up. And next step is the stepping. The stepping that does not include I want my patients to walk or directly. Now, okay, my patient is standing right now. I'll make sure my patient starts walking or running. No, I want my patient to first lift up his legs, step like a staircase stepping we do in the at gyms. So we have to make the patient steps up, stepping at his standing place. He steps for 20 times, 30 times, going slowly. Then stepping can start from the area of the bed, so he can move from 5 steps, 6 steps slowly. Then we'll make sure he moves slowly and goes the oxygen goes will go inward movement. And so this is all about your early mobilization. And then there is stretching. So the things we have seen, this is a very, very rarely seen with the patient. Anyone tries and does this thing. So we have this stretching. How can a stretching is going to help the patient even to make sure he's open up his lung? But there are studies which have been actually showing that the patient may be encouraged to engage in routine stretching thrice a time can change to increase in compliance or in volume by 50 ml, which is very, very huge number for a starting patient. If I say the lung of a city severity score of 22, the lungs is completely gone and pushed out, I make sure this 50 ml will count for my patient. So what all stretching should include? First is the neck, upper chest of the stretchings, acromion major, lateral chest stretch, flexion, extension, mobilize the facet joints, dorsal chest walls have been showing in less compliant in the patient with ARDS. So you have to make sure your small number does count. So you can make sure your patient does a stretching at least thrice a day. Now let's look after what are the exercises I can look after into it. So now I have done with position management first thing is done now, and later on we have done with or early mobilization techniques. What could be the or respiratory exercises when there is a high frequency chest wall oscillation? So this is also known as a bus therapy. This is nothing but basically a vibration therapy for the chest. So what could be this? The help of the use. Use could be, it will help out your mucociliary clearance. It will also help the patient's pulmonary hygiene to go out and make sure that those clots and those consolidation of atelectasis, which is the stopped inside the lung, which will start opening of the alveoli. The next therapy, your oscillatory PEP devices, which is a cappella vibrator PEP therapy. So you need to start performing this exercises and use of this device. You have to make sure it is very, very common in COVID patients. So how does cappella and vibrator PEP is has the same mechanism for pulmonary hygiene, and plus it will also act as there is some PEP therapy. It will also help to open up their alveoli in a small number slowly. Then there is chest therapy. In chest, there is hand percussion and vibration therapy you can use that for the pulmonary hygiene. Incentive spirometry has shown drastic changes in all the patients in with respective mild, moderate, or severe patients. So you have to start performing, even though the patient is on HFNC, we can perform the incentive spirometry to the patient. We just have to make sure that the FiO2 requirements has come down first. So incentive spirometry every hour with 5 to 10 reps is enough. You don't have to rush on the patients. Then these are the patients where we can use active cycle breathing techniques to the patient. This is first where could this patient be used? This is the patient which has been you wanted this patient to be extubated after that say 7 days or 20 days of ventilation. So you have to use this technique so that the patient's cough is coming out. So your clinical judgment and your clinical experience matters, whether which of the exercise is currently needed for the patient. That plays a very, very major role. So you have to make sure your clinical experience or the clinical judgment plays. So what are the measures I will look after into it? So this mainly includes lung recruitment, sputum expulsion. It does not require therapists to stay along with the patient, the patient contact. You have just taught the patient how to perform the exercise. You can stand out and make sure that you are not getting affected by the virus so easily, even though you are in the complete PPE kit standing out there. So the management should not trigger. You have to also always this is I've been saying from the starting of my slide that management should not trigger severe curve for increased work of breathing. So your rehabilitation is on completely monitored. So I can see there's a small picture which show what is your active cycle breathing. If you can see the first with controlled breathing, how does it should be performed is shown over here, that you have to inhale deeply through your nose and you have to keep your hand on your belly button, press in and exhale out slowly through your mouth. So this is nothing but a first sleep breathing which will help the patient to reduce the work of breathing. So if your patient goes into any work of breathing, increase in work of breathing or distress, you just make sure you calm the patient first and ask the patient to do this exercise. This will automatically increase, it will automatically reduce the work of breathing of the patient, no doubt. So we have seen this. So this was all the things which you can do in the very, very severe acute phase. So now there is so those were the severe patients. There are so many things we have to play around when you're going on the rounds. So it's your respiratory therapy is just not anymore. Just we have to go and play with the ventilators and going and doing a clinical management. It has widened up so much that you can't even sit around for a minute. You have to continuously perform exercises on all the patients. So now these are the mild patients. These are the severe patients. This is somewhere between mild to moderate to severe patients. These are not extremely severe, but these are severe. So these are the patients which fall into moderate to severe. So evaluation and monitoring must be conducted initiated from respiratory rehabilitation as earlier. So I'll go with the short up. So how does, what all things I need to look after on the patient breathing support and breathing going on, and what are the exercises or things I need to look after it. So if the patient is mechanically ventilated, breathing monitor, clinical condition parameters and adjustment of the oxygen therapy should be there. In the just physiotherapy, there should be you should make sure there's non-productive should be situated to avoid fatigue and dyspnea. You should make sure obviously bronchial clearance technique, hypersecretive patients with chronic respiratory distress. So you have to make sure you have to look after into this patient. This patient might have all these things. And these are the exercises which I need to in chest physiotherapy. I need to prevent and solve this problem. And so how to prevent a disability prevention in all the patients, which is mobilization and positioning, active limb exercises and muscle reconditioning. Neuromuscular electrical stimulation technique could also be used. Not these are majorly higher centers. Respiratory muscle training in case of inspiratory muscle weakness. So in acute phase, we can do this. So when now in soon as of the start, so in the post-acute phase, so we have seen severe patients, we have seen moderate to severe patients. When we see these are the mild patients or these are the patients, the post-acute phase, they're about to go home or discharge from the acute care thing, or they are going from the higher center to the lower center to the intermediate setting to the patient. So in here there is some changes in your criteria and immediate termination. You need to look after it. So this could also be patients where you would be performing pulmonary rehabilitation at home. So over here the heart rate should be less than, more should not go above more than 100. In exclusion criteria is if your heart rate is more than 100. Earlier we have seen it was more than 120. Over here the changes is 100. We don't want patient heart rate to go even more than 100. So if the patient BP goes less than 140 or 130 and 90, so you have to make sure the blood pressure should not fall. Saturation, patient should be maintaining 95% saturation or more. You just can't take a patient who is on maintain 90 saturation, 90. No. So this could be exclusive criteria. So you have to go very, very slow in this patient. If a post-acute phase patient is there, that does not mean that you have to stop it. But you're not supposed to take the patient at all as the exclusive criteria. But you are supposed to monitor them very, very closely, and you are not. You just can't give them higher exercises to perform. Other diseases that are not so suitable. So this are some changes experience with the heart rate. So what could be the immediate termination? First could be the rise in temperature, fever. So while performing, if you see there is severe changes in respiratory symptoms, this is fatigue, chest tightness, chest pain, dyspnea, severe cough, dizziness, headache, blood vision, heart palpitation, perfumes, or unstable guide can. So this, you are seeing any of this, please stop it right there. Now, so what am I supposed to do with this patient? What am I supposed to do with this patient? Now I know the criteria where and what to stop, which all exercise I can do. So this is a mild and elderly patients after discharge somewhere around, mainly consists of improving physical fitness and psychological adjustment. Okay, so you have to make sure. So what could the progressive exercise I should advise? I should give a small number of aerobics, deep breathing exercises could be given to these patients, which is personal breathing, ACBT. So this was the patient in the post-acute phase we earlier saw. This was the mild patients. So now if the patients were critically ill, now they are about to go home. So these are the severe patient in the post-acute phase. So what am I supposed to do with? So monitoring the patient, weaning should be looked after to it. Monitoring of parameters, mechanical ventilation is if tracheostomy is needed, not needed. Need of oxygen therapy, adjustment of oxygen therapy, problems related to tracheostomy, which is phonation, secretion, ambience, the tube is getting lost, secretion clearance should be bronchial clearance technique to be followed regularly in this patient. Disability prevention and disability prevention should be there in this patient, because there's a high likely chance if the patient is just extremely fatigued, there's a loss in muscle mass in this patient, and because of the lack of nutrition. So we have to make sure there's no disability to be given to the patient, so that can patient for worsen the patient's life. Mobilization activity, exercises, respiratory muscle training again. So now all of the things I have been seeing. So what could be the reassessment? So where my reassessment will start? As a minimum, the adjustment will be at completion of the pulmonary rehab program should be repeated every. So as you know, in this patient will be from the day one. When you day one, you'll be seeing this patient, you'll be mentioning the heart rate, respiratory rate, your FRC, your if you're doing spirometry or acapella, the tendency rise in volumes. So these are the reassessments which could be done. But so first is, I can say, lab investigations include. So reassessment, which can be physical examinations, lab tests, lung functions, nutrition screening, very very important. We should not miss out this, and changes in imaging. So exercise and respiratory function, how you can check that, which is basically by doing 6-minute walks, respiration, muscle strength, balance, functional fluid, functional evaluation, physical activity evaluation, joint round of motion, evaluation of activities of daily life. So this would be in the post-acute, where the patient is gone home, trying to try and doing his work and doing back to his normal life. So these are the evaluation we can see from day one till the patient is gone home. Thank you. So I'll be ready for your questions as per ma'am has said.
Thank you, Ashish. Thank you. Thank you, Ashish. It was a very wonderful sharing of knowledge about one of the most discussed topics in respiratory care today. From your vast experience, it is very evident how much effort you guys, I know your team personally as well, you're putting in for saving lives of many, or in a words, thousands of needy patients. Hats off to you. And thank you, Ashish, once again. And please be available in the discussion room. There are some queries from the audience, and we'll be redirecting them to you during the discussion session at the end of the 3 talks. Thank you once again. And
thank you, sir. Thank you,
next, I'm inviting one of the distinctive face of IARC and Indian respiratory therapist, the charming vibe of IARC, Ms. Madragauri Shivade, to deliver a talk on mental well-being during COVID-19. Madhura is the Associate Vice President of IARC, Vice Chair of the Indian Academy of Respiratory Care, and she's also the Associate Editor-in-Chief of the Indian Journal of Respiratory Care presently. To be honest, she's the master brain behind this entire webinar series. She has done enormous job in designing the structure of this series, inviting faculties, moderating multiple sessions for the past 3 continuous days. Simple words are not enough to thank you, Madhura, but we, on behalf of IARC and the entire respiratory therapy people across the globe, we thank you for all your efforts, and this is actually bringing more accolades in our efforts to fight this pandemic. We are eager to listen to you, Madhura, and the platform is all yours. Please begin your session. Thank you.
Thank you, Jitin. That was quite an elaborate introduction. Thank you so much. I was not, I don't think I am that great, but thank you. This is all efforts of all the academy, the IRC ethics committee, executive committee team, all of us are working together. So thank you everybody for being a part of all of this, and thank you Jitin for silently, as I keep saying, you are leading from the front without making any noise. So thank you for that. I will close my camera right now because my internet is not working a little too well. In case you are not able to hear what I'm saying, please do let me know. Otherwise I'll just keep on blabbing. So yes, okay, I think that's what I did. All right. So today's topic that I am going to present to you, if this goes into presentation mode, hopefully, yes, is on mental well-being during COVID-19, and it's a very light, well, it's a very deep topic, but the way I'm presenting it is going to be very light because for several reasons. I will not be taking much of your time, and what I want to do here is just give you some tips and tricks in terms of managing your um, patient's well-being, managing your own well-being, managing well-being of the common, man in general. So without wasting much time, let us begin. So my first thing I want to do is give you a disclaimer. The most of my World Health Organization has helped me make this presentation today, because most of the images that I've taken are from the website that I have mentioned here. I would like to say that I am not a professional psychologist. So in case you encounter something that needs professional recommendation, please do forward that to the professional. What we will talk about today and what I am here to do today is talk to you or explain to you or show you things that every healthcare professional should know and should practice every day in terms of mental well-being. So let me begin with welcoming and congratulating everybody, and let us, I think this is the best time that we are presenting or making this presentation is because it's Mental Health Awareness Month. The month of May is. So everybody, we need to be aware of each other's mental health as well as our own, because that's the half battle that we need to win. So yeah, so the first part of my session is going to look into the mental well-being of COVID-19 patients. So why are we talking about mental well-being today? Everybody is into mechanical ventilation. Everybody wants to know about oxygen therapy, and everybody wants to know about HFNC, etc. Falana Dimkana. But thank you for all those 20 people, 20 plus people listening, still listening to this talk today. Why is it important for us to know about mental well-being? Well, if you look at this image, you will see that this is what we are facing. Everybody's facing. Everybody is scared. Everybody is worried about the danger and contamination, spread of infection. People are blaming each other. People are blaming the Chinese people who started where this disease originated from. Everybody is undergoing a lot of trauma and the stress that is involved in it. People are constantly online. People are always looking up facts and figures just to understand, uh, just to seek some reassurance, as this image is showing us. And the most important is the socio-economic factors that are playing a big role. People are unemployed, people are not getting enough money, people are losing their jobs. All of this is playing a huge role on something which is anxiety and depression, which is commonly one of the things majorly seen in COVID-19. And with that, you can see anxiety, depression as the major component. We've seen people go buy toilet paper, so that's panic buying everybody is doing. People are avoiding each other, people are discriminating each other, and of course people who are isolated, who are stuck at home, they are undergoing a different ball game of mental health issues because of being isolated. And all of this is why we need to look into and talk about mental health and mental well-being. Generally we would see somebody with all of these symptoms that are shown, like restlessness, is fatigue. You will see somebody with anxiety will be always worried. They will always have increased soreness, muscle ache, impaired concentration, irritability, difficult speaking, sleeping. You're talking to them and there's a blank on their face, nothing is being registered, and then they come back to you with the same questions again. Depression, you will see a lot of low mood, agitation, there's fatigue, people don't want to eat, or people excessively want to eat, both ways. Sleep again plays a major role here, and again difficulty in concentration. So as healthcare professionals, we must counsel our patients. We must know how to counsel our patient, and it's not just the patient, but also our patient's family members who come along, tag along, who want answers, who want explanations, and they are just seeking some sort of a validation from you. So as healthcare workers, when I say patient counseling doesn't just mean just patting their back and saying, oh, I'm so sorry, you no, that's not what it is. Counseling components, you talk about the disease, you tell them what they are going through, you tell them how do you prevent it so that it doesn't spread to their family members if they don't have it. You talk to them about treatment. Why are you giving this type of a inhaler? Why are you doing this type of a physiotherapy? Why do you want that patient to be sleeping on their tummy in a prone position? Why do you want them to wear a mask? All of these is part of patient counseling and education, which you must do. We just looked at pulmonary rehabilitation, brilliantly explained by Ashish. There are a lot of myths and misconceptions, and I think the biggest contributor to this is WhatsApp. So a lot of false information is being passed on WhatsApp, and people are just believing it. Of course, we need, through counseling, we need to support our patients, or just anybody in general, for the anxiety and depression. At home measures is what we need to tell them about, because nobody else is doing that, nobody knows what to do at home. And of course, talk to them about nutrition. You should always, this is very important, you should tell your patients to not panic, absolutely not panic, because panic, when they go haywire, they go crazy, they don't want to listen to you, they will be worried. So tell them that you should talk to somebody, you should talk to, if they are willing to talk to you, listen to them, listen to their problems, tell them they don't have to be so scared that it will affect their lives completely. So that is one important thing. Two is, you should tell them, obviously, and I will tell this to anybody who is listening to me right now, stay away from social media, stay away from your news channels, your Republic TV, or your Arch Talks, or your NDTVs. Listen to the news when it is needed, but not 24 hours. See, we had good times when it was the Doordarshan just having their news at the evening time, 2 hours they would show us what's going on in a small gist, and that would be it. But right now, because the channels have to fill information 24 hours, they have to broadcast something, they keep on hampering and harpering the same thing. That really affects your mind. So tell your patients, or tell anybody, counsel them to tell, to step away from the computer, smartphone from time to time. When you do come back online, focus only on the correct, the information providers that are correctly providing you. So that will really help. Then of course, you talk to your patients, or you talk to people who you are trying to counsel, is how often you should wash your hands, whether you should, what you should do to cover when you sneeze, etc. Limit social gatherings. Don't, when they're telling you to maintain a distance, you should maintain a distance, and not like something that we see in this picture. Always wear a mask, sanitize your hands. All of this that we've been dragging, we've been talking about since last year is important. Something like this. Avoid social gatherings, or limit the social gatherings. This was a recent photograph, I'm sure you all have seen. I don't really think this was a good idea that they have done, even though it was in midair. If you really want to conduct some sort of a ritual program, gathering, marriage, whatever, do it in a very small way. Just, you don't have to have so many people around, because this is very dangerous. So all of this you should talk and tell your patients. Then there are a lot of patients who are at home, they're sad, they're sick. What we as healthcare professionals need to do is provide them compassionate care. They need to be, if for example they're in the hospital, they are alone, you know, you can encourage them to get in touch with their family members, talk to them on the phone, or talk to them via video call, whatever it is, that will give them comfort during their isolation period that they have. Of course, if they are not able to meet them in person, as I just said, online connections, social connections, encourage them to look at the better part of social media rather than the negative aspects of it, and encourage them, like you can see in this photo, this patient is on a call with his family, something like that. Now, all of this is good. What this photo is telling us, that we need to focus on what we can do in our lives. We've gone through so much, but still there is so much we can do, all of that. But what I would like to tell you is, don't promote false positivity. What you should do is, you should help them understand the issue and then move forward in a positive manner. So that way they have accepted that there is something wrong, and then they are willing to move forward knowing that there is something wrong. If you provide them false hope, false positivity, that is just going to come back and crash, and that's not going to be good for their mental health. So you should always be careful of how you project things, and don't just say, oh, stop with all of the negativity, be positive, be positive. No, that's not going to help. So you need to be very tactful when you are dealing with these issues. Of course, patients will feel low. Everybody feels low. You should tell them, and they will withdraw from. They'll go into their shell basically. So you should encourage them to do good things, do positive things. I'm not promoting positive. I'm not saying false positivity, but things that will give you some joy, some happiness. Breathing exercises that we just looked at, some at-home exercises. Maybe they like reading books. They like listening to music. So you should encourage them to to put their mind into things that will calm them down and basically help their mental health. Another issue that comes up is smoking, and I think this is the best time that you can tell your patients about smoking cessation, promote healthy lifestyle, talk to them about the different aspects of how they can get rid of their smoking habit. Alcohol also is part of this, so you can give them tips on how they can stop smoking, seeking expert advice, or how they can manage cravings. Also, it's always good to have a team for smoking cessation, so that if you need your patients to have something prescribed, you have a doctor on board, you have a nutritionist on board, you have a respiratory therapist on board. So it becomes a team effort, and you help your patient quit that bad habit. Because of course, smoking, all anyways, we have been facing such issues with people smoking, and COPD, etc. And then on top of that, when you have COVID, that's that's like the worst. And the other thing is, there are risks of fire hazards, and uh, you know especially if your patients are on oxygen therapy and smokers. So this is, I think, the best time that you can hit the hammer on the on the so not on the patient's head, but metaphorically speaking, you can help them. The other dimension, or the other group that we don't look at, is the children. But I think the children have suffered the most during this pandemic, either because they themselves were infected, or just plain simple, schools were closed, no classes, they were not allowed to go down, and they're building and play with children, and uh, etc. So maybe you can encourage your patients and your family members to create activities, and help your your children learn, as well as play, as well as feel happy. So that is something that you can, as a healthcare providers, counsel or guide your family members and the children and the patients to do. Now, COVID-19 started with a lot of stigma, a lot of discrimination, and I'm sure most of you have faced this discrimination. I can give you, without saying names, I can give you examples of people, of RTs, who were kicked out of their places that they were living in, because they were going and managing COVID patients. and instead of celebrating what they were doing, they were being discriminated against, and I think that is very, very bad. So part of mental health and mental well-being is knowing as well as educating others about the social stigma and discrimination. So it's very simple, because viruses don't discriminate. They have affected every country, every human being, every color, every gender, every race, etc. Unfortunately, what this does is it gives rise to more anxiety, more issues with mental health, and that's something that we don't want. What we should do is we should all be together, and we should all be in solidarity, not stigma is what the WHO hashtag is, but we should all support each other rather than pulling each other down. So if you know somebody is discriminating against COVID, please stop that. You have the right to go and educate, counsel, teach, explain whatever them, so that it doesn't happen, especially to our fellow respiratory therapists. Now, domestic abuse was already always prevalent, but it has grown since COVID-19, and majorly that is because of the lockdown. Domestic violence is likely, and it has already increased due to the pandemic before and after. And children, women, and older people are the highest, or at the high risk of domestic violence. One, because children, for example, if they get online abuse, they have the risk of spending more time online. Women get sexually and violently abused at home, they may get, similar to old people. So we need to come together as a healthcare community and um, create platforms, create some sort of a help policies, procedures, where we can identify somebody who has been or who is undergoing, unfortunately, domestic abuse at home, and help them, guide them towards it. There are, if you go on this website that I mentioned here, or if you just go and type domestic abuse, you will find n number of institutions and organizations who are doing fantastic work to help all of these victims. So we need to be aware that something like this exists, and we need to do something about it. Now, death is a very serious matter, and is very, very, very unfortunate that, as healthcare workers, especially those who are working in the ICU, they see this very often. COVID has brought on more number of deaths than you can imagine, and it's very sad, not only for us, for the patient, the family. So losing someone is very difficult for them. So that is something that we need to look at, think about, or be aware of. We need to be compassionate when we are around, people who are dead, dying, the family members. We need to support them. We need to be mindful of what we are doing, especially, otherwise, see what happens is, after a certain period of time, you start not feeling any feelings for such instances, and then, god forbid, you go ahead and you do something, you chit chat in front of the family, or laughing, and you don't want that. So be very, if you can't do anything for them, at least don't do something that will damage the situation further. So be very mindful and be compassionate and be patient in handling these situations. And it's very unfortunate, everybody has to face this. um, but this is something that, when it comes to mental well-being, is a very important, is a big aspect of it. I won't go into the details of death though. Another thing is suicide. Suicide rates have gone up, especially during COVID, because of anxiety. People are losing their jobs. There is a lot of stress. People are isolated or lonely at home, and that is leading them to, kill themselves. Again, as healthcare professionals, you are not going to everybody's houses to look at what they're doing, but again, we can educate people, and we as ourselves can just be mindful and watchful of these different warning signs. If you know someone, or if you feel somebody, maybe your colleague, maybe your patient, maybe your employer, your employee, whoever it is, just be mindful. And if you have the slightest of the doubt that there's something wrong with them, definitely please support them, guide them, show them the right way. It's very help is available everywhere. If you just go on Google and you type the word suicide, the very first thing that comes up is a big a bold a phone number, basically, in a very big font, where you can call and ask. So it's always, everything is already there. You just need to guide them, point them to the right direction. That was a little bit about patient centric mental well-being. It's a huge topic, and as I said, this is just the tip of the iceberg that we are looking into, so that we are mindful, we are aware of what goes on around us. But I do want to talk about mental well-being of healthcare professionals and students. Why do I want to talk about, why do I really care? Why do we really care about healthcare professionals? They are okay. No, that's not it. Isn't this something that we see every day? Often, yes. Please disregard the mannequin, but just imagine that there's a patient here. You see such scenarios, there's blood everywhere. This is your typical ICU, and unfortunately, if nothing, it doesn't work out, this is what the end is. And this is what happens to us. What is it that happens to us? Everybody goes through it, everybody suffers it, but nobody really knows what this is. What I'm trying to talk about is burnout. Burnout in healthcare professionals is big. It is really big. Thankfully, it is being now recognized. People are trying to work towards reducing burnout in healthcare. See, if your healthcare professionals are not up to the mark in terms of their physical and mental well-being, how are they going to cater to our patients who need their help? So we need to look and support our healthcare professionals that way. So, what is burnout? It is work related stress syndrome resulting from chronic exposure to job stress. Now, just think about your own self. You go back time to the first time you started working till today. So, you will then realize that you have also gone through so much stress that now you don't care anymore. So, that attitude basically is part of burnout. Now, burnout has been divided into these 5 stages. One is your honeymoon phase. You just started your job, started getting money, you are accepting everything that comes to you, you're very excited, you want to do whatever has been asked to. And slowly you start working, and then stress starts develop. You see serious cases every day, you have to wait extra time because the next RT hasn't joined you, or you are yourself sick and you're not able to work. All of these issues, your manager is not behaving properly with you, you're not getting the salary you want. All of these things start add on to your stress. That leads to all of these examples: the anxiety, the cardiovascular symptoms, irritability, this, that, all of that is being given. This continues because nothing is done about it. That From that onset of stress, it becomes chronic stress. Chronic stress, you are even more irritated, you're more resentful. If somebody requests you, even though you don't want to do work beyond your time limit. If somebody requests you to spend some 2 hours or 1 hour of your time on your holiday to present a lecture, people don't want to do that, because this is burnout. They are already over everything and they don't really want to participate. That turns into burnout, where it becomes even more difficult. It starts affecting your physical health, and then your habitual burnout, which is your chronic sadness, chronic mental fatigue, depression, all of that. Going from the honeymoon phase of stage 1 to stage 5 is quick. It doesn't take much time, but it happens, and if you don't do anything about it, that's going to hamper every healthcare professional's mental health. We already have a shortage of healthcare HCPs. On top of that, this is an impending doom. So what I want to say is, it's okay to feel your things, it's okay to not be okay. You are not God. You are a human being who knows more about managing mechanical ventilation, who knows more about intubation than anybody else, who knows more about oxygen therapy, or all of these skills that we have. But there is a limit to everybody. Everybody does go through all of this stress. So you should always, you as a healthcare professional who is listening to me right now, talk to your colleagues, talk to your boss, talk to your family, just open up and, you know, share your stress that you have with them. Don't don't keep everything inside of you. You know, everybody is human and everybody goes through, I don't want to use the word, but everybody goes through shit. So What you can do is, if you feel that you have been burnt out, you are suffering, there is a lot of things that you can do. You can intentionally employ coping strategies. Now, coping strategies, for example, is, if you're working 12-hour shift, you have a lunch break for maybe half an hour. Try finish eating quickly for 5-10, in 15-20 minutes, and the remaining 5-10 minutes, just go take a nap somewhere, go listen to your music, go watch a small video on YouTube, do something that will change your focus. Or do, after your work is over, you can engage in physical activities, go play a game, play badminton, football, watch movies. Not right now, obviously everything is closed, but at home you can Netflix and chill. Who's stopping you from doing that? But do that intentionally, so that you have something else to look forward to and to calm you down. Of course, please ask for help. If you think you need help, please ask for help. Everybody is around you, is there to listen to you and is there to talk to you. So ask for help. Now, I would like to please emphasize this. Dear supervisors, managers, and my professors who are listening or who might be listening to me in the future, do not forget that people who are under you as students or as RTs are human beings. So you are responsible not only for the work that they are doing, but also for them as well. So, you know, try and adjust little things that can make them happy. Staffing procedures, schedules. If somebody has come to you genuinely asking for a day off, even if you feel that their reason is not that, you know, um, it might not be a great reason to take a leave, but just give it to them. It might just be that they need a mental break. um, Monitor your staff may not come to you and talk to you about their issues, so help them, give them the time that they need, create an open environment for them. That will go miles and that will work wonders. Students, I haven't forgotten you. I know students are also going through a lot of stress right now, especially because the colleges and universities and schools are closed. What I would tell you is, of course, you have to listen and study, but then after that study period is over, change your, indulge in something that will take your mind off of all of that. Make sure you sleep well. Don't stay awake watching something or doing something chit chatting till 4 in the morning if you have a class at 8 o'clock in the morning. Regularly eat, regularly stay connected with each other, just chit chat with your friends, outdoor breaks. All of this is applicable to school students, to undergraduate doing BSc, BA, bachelor's, somebody who's doing uh, undergraduate, before school, after school, graduate, postgraduate, of course PhD, and I haven't forgotten postdoc as well. So even if you're doing postdoc, and if you're listening to me right now, make sure you take care of your mental health. That is needed. If you are doing a 9 to 5 desk job, there might be RTs who are not in the ICU setup right now, such as myself. You have some, what do you say, plus point, I would say, where you are not um, seeing death every day. There is other type of work stress, not, so your stress is not comparable to the ICU stress, although you have a lot of stress. So make sure you organize your time, open communication. You work from 9 to 5. After that, make sure you switch everything off. If you are a manager, don't message or email and make your employee work post the time that you have been designated, unless it's a deadline. Every day you push them to make, to work later. You message them, you email them at non-working hours. That's not right, because even if the work is important, it does affect a lot of mental health. So so you need to ensure that you have your you try and manage some balance between your work and um, your mental health, your physical health, all of that. So that was just very brief, very mm, simple, basic, I would say, about mental health. Mental health is important. It is important for your COVID. It is important for your other disease patients. It is important for anybody and everybody, no matter where they are, how they are, what they are doing. So as again, back to health, being a healthcare professional, you need to be able to counsel somebody, you need to be able to understand what they're going through, you need to be able to speak up if you yourself are going through it. And I think that just be patient. Don't be irritated because a question is being asked to you by somebody and you don't want to answer that, because keep yourself in their position. If somebody comes to you and is not explaining to you why there is a tube down somebody's throat, why is that person not being able to meet me or whatever, you will get upset. So just be mindful of that. So with that, I would like to just share these three um, um, reading material. I would say the best is the WHO illustrated guide. Please, it's available on the WHO website. Their guide is all pictures, hand drawn, that's illustrated on how to manage stress. The other is guidelines on managing mental illness in hospital settings during COVID-19. And of course, your ICMR guide on psychosocial support to your family members. So please read all of these three. They have very good tips and they have gone into depths of managing mental illness beyond what I have talked about right now. That will definitely help you. So with that, I would like to share the last slide and say thank you for patiently listening. This, I know this is not the usual respiratory therapy topic that we usually do. However, this is very relevant. This is very important. Think about it. It will definitely, give you the direction in terms of, if you start using it, your patients will definitely show you you know, um, the fruits of what you're basically telling your patients. They will be calmer, they will be happier, they will have less anxiety, and that will probably be the half battle won for you. So thank you so much. If you do have questions, please ask it in the YouTube chat box, and with that we will move on to our next session.
Thank you, Mathura. Thank you so much. You kept virtually, all of us hanging on every verse that you speak about. That was absolutely an incredible talk about this burnout, and which every one of us is going through now. It had many lessons also. Like, it's not only the healthcare providers; it is important. It is definitely extraordinarily profound and effective for the public as well. And your slides were so calm, and it was so funny as well to look into the pictures that you incorporated. Thank you so much for that a very interesting talk. I kindly request you to introduce our next speaker, Ms. Mridula, and move on to the next session. Thank you so much.
Thank you, Jitin. Thank you so much for your kind introduction as well as your comments. Okay, without wasting further time, I would move on to our next session. Our next session is going to be taken by Ms. Mridula. She has been instrumental, and she has been in the game of teaching for quite some time now. And today she's going to talk to us about COVID-19 in children in pediatrics. It is a very relevant topic since we are seeing a lot of children being connected, uh, children being infected because of COVID-19. So I think this I'm looking forward to listening and learning from her in terms of how we can manage in case we have to ever manage a child with COVID. She is an assistant professor at the Manipal Department of Respiratory Care at Manipal University College of Health Sciences. So welcome, Rudula, and please go ahead. Thank you.
Thank you so much, ma'am, for the kind information. And I am so grateful and thankful for you to giving me this opportunity. So before moving ahead, I would like to tell that it is in the home setting, and please avoid the unnecessary noises around me. So without any delay, I'll be starting today's topic on COVID-19 in children. And to start with, I'll outline what we are going to speak today. So we are going to speak about the changes in epidemiology for the second wave of COVID with reference to children. What is the basic pathophysiology, mode of transmission, and clinical features in the children? And we are going to see what makes it different in the pathophysiology, why kids are not getting severely affected. And we are going to see how do we assess COVID-19 based on severity and management with that severity. And the last topic, I'll be talking about the multisystem inflammatory syndrome in children, which is often associated with COVID-19. So that would be the flow of the lecture. So the first slide, I have taken this from the government site, and it tells us about the numbers as to how many numbers are getting number of people in India are getting affected with COVID-19 based on the age. So as you can see here, the number or the percentage of people getting affected below 20 years is less than 12%. And if you dig into the data, the mortality of the people who are less than 20 years is even lesser than 3%. So it has not affected majoritarily in the children age group, but definitely you can see that it has hit the youth predominantly. So this is the current data, and the possible reasons why there is a news of third wave being very exclusive for children is because last year we had first wave. It has generally affected the geriatric population. The second wave is for the population from 20 to 45 years mostly. And the possible reason could be for the third wave to be exclusive for children is because they are non-immune and they are not affected till now. So maybe that is the only reason, but there is no scientific data suggesting how severe it would be and when the third wave comes. And definitely it won't be just for children, it will affect all, but we are expecting more number of kids to get affected. So quickly moving on to the pathophysiology of COVID-19. So it is basically from a physiologic host response, that is what a general person will respond to any virus entering the body, to the pathologic host response, where even after trying with normal physiological immunity responses, it is not able to tackle or eliminate the infected cells. So first stage in pathophysiology would be the viral entry and the early infection. So as you can see here, if SARS-CoV-2, that is the virus responsible for COVID, is entering into any person, the first major expression of the virus is on the ACE2 and TMPRSS2 receptors in overall respiratory tract. So it is a respiratory infection. So ACE2 is angiotensin converting enzyme 2, and TMPSSR is transmembrane protease serine 2 receptors, which are basically in the respiratory system. So it sticks to that and it replicates and the pyroptosis starts. Pyroptosis is a very algorithmized way of immune system to response. So it is a very good way how body will respond to it. Second one, the body has the second stage. Now body has come to know that there is some virus which has come in, and now I have to show some response to it. So that is called the second stage, which is host immune response. So in host immune response, they will recognize what is the damage associated molecular pattern, and the body will recognize what is pathogen associated. So in second one, for DAMP, what we call it as damage associated molecular pattern, the body will recognize the virus and it will start its early phase called as macrophages will go to that side, or dendrite cells will start engulfing that virus. And in the late phase of this, the cytotoxic T cells, that is normally called as T immunity or T cell immunity, it will get started, and it will try to eliminate this infected cells. So in host immune response, macrophages and cytotoxic T cells are the heroes, and they'll try to eliminate this infected cells. But if they are not able to do that, then we say that the COVID-19 or SARS-CoV-2 is going to pathogenic host response pathophysiology. That means stage 3, which we call it as hyperinflammatory phase, where the person who has got affected will go from the mild stage of the disease to moderate to severe when he crosses the second stage of physiologic host response. Now, in pathogenic host response, the body has to work even further to eliminate these cells. And what they'll do is they will further start the cytokine storm with interleukins and enzymes like tissue necrotizing factors, which are very heavy inflammatory mediators. And so excessive infiltration will occur of these immune cells, especially in the lung, as we are talking of COVID, which is a respiratory virus. And for this, the entire body or the system, it will start overproducing these cytokinins. So when this stage is reached, the regulation by the body is very aberrant, and that's why it is called as hyperinflammatory phase, which is not generally normal. And the last phase, that is the fourth phase, when we talk about the pathogenic host response, is multi-organ dysfunction. So now, because of this hyperinflammatory phase, it doesn't restrict itself to the lung, and it will go into the extrapulmonary organs like liver, kidneys, brain, your blood, and it activates the procoagulant response. So now it is getting into the bleeding cascade or coagulation cascade. So this pathophysiology, with this slide, I want to tell that after 2 stages of physiologic host response, if you are getting any kid with any symptoms which are responsible for giving you stage 3 and stage 4, they are severely affected. And now I'll be just summarizing this clinical stage. So when I plot the severity of illness with the time course, in stage 1, early infection, generally they are asymptomatic with mild symptoms. Then if they move on to the stage 2, which we call as pulmonary stage, they will have no hypoxia initially. Then they will lead to stage 2B, which is hypoxia with no organ dysfunction. Then further with the time course, if not treated properly, they will move on to stage 3, that is hyperinflammatory phase, which will have hypoxia with organ dysfunction. Again, in that, you have a stage where it is not acutely life-threatening and a stage where it is acutely life-threatening, generally called as MISC or multisystem inflammatory syndrome. So this is the spectrum of clinical stages. And as the time progresses, the severity of illness also increases with stages. So till stage 2A, we consider it as physiologic host response, where body is good enough to take care of whatever invasion is being done by the virus. But after that stage, we call it as pathological or pathogenic host response, where it will go into more efforts to throw that virus out. And this is the basic pathophysiology of coronavirus. Now we'll try to look into few reasons why children are not severely affected, or they are not frequently affected, or most of the cases, whatever we have seen, are mild in number. So this is a diagram where they have represented these 5 reasons by the numbers. I'll go one by one. So the first number here is denoting the nasal mucosa. So as I've told, the main site of attack of SARS-CoV-2 or SARS-CoV-2 is your ACE2 receptors. And the basic reason why kids don't get severe disease is because they don't have more ACE2 receptors in their nasal mucosa. So these receptors will multiply in number as you grow. So they have very limited ACE2 receptors. And also coronavirus will come up with common cold, and for kids that is protective because it mediates their cross reactive T cell immunity. So that might be the first reason why they don't get severely affected. Second reason, when you look into the alveoli here, in alveoli, your TMPRSS2 is present in type 1 alveolar cell, and your ACE2 is there in type 2 alveolar cell. And as I told, they grow with age, or the number grows with age. So again, they have reduced number of these receptors itself. So that might be another cause why they don't get severely affected. Third one is protective Th2 immunity in children. That is a cell-mediated immunity, or cell innate immunity, which is generally activated in children more than adults. So that might be the third reason. Fourth reason is something called as trained immunity in the children, because they will get lots of immunizations, they'll get vaccine shots. So their immunity is trained with that, and they are always ready to face infections. They will have so many frequent viral infections. So their immunity is trained because of the live vaccines. And that's what also it protects them for the from the severity of the disease. And last reason can be production of lower levels of inflammatory cytokines, especially the interleukin 6, which is activated in the hyperinflammatory stage, the stage 3. And since they have the immunity, which will not produce this interleukin 6 majorly, so that might be another reason why they don't get severely affected. So 5 reasons, and they are very good reasons pathophysiologically. Now we'll see what are some other reasons, what makes them reduced, what makes them to be very less susceptible. So by a study from excellent physicians in India Journal of Pediatrics, they have told that in general, children have less susceptible to this virus. That is, all the variants of it, SARS-CoV-1, SARS-CoV-2, or MERS-CoV. So all these, they have less susceptibility as compared to other respiratory viruses like RSV, or respiratory syncytial virus, or influenza. So they are overall less susceptible to this strain. And what it was observed that most of the infections, whatever we saw, less than 12%, are because of the infected adult family members. And that's what we are going to do, that isolate the infected people properly. That's the whole, that's the most seen reason why kids get it. So that's what isolation of individuals may reduce the exposure directly. So it is direct contact exposure. And among the studies of household contacts, odds of infection in children were significantly lesser than elderly, with odds ratio of 0.26. So even if you compare the infections which were because of the household contacts, they were very less in children. And very obvious reasons like lack of comorbidities, they don't smoke, they don't have diabetes or any other risk factors which is lifestyle related. So they are less susceptible for a severe disease. So, but that doesn't imply that we will not get any severe diseases. But these are the possible reasons why even if they get COVID-19, they will be quickly, they'll be getting quickly good, or they'll be quickly cured, or they will get a milder form of the disease because of the reasons I told in last two slides. Now moving on to what is a mode of transmission. So lots of debate, and finally the modes of transmissions were contact. So directly, if somebody is getting in contact with the infected person, sure shot you're going to get COVID-19. The droplet infection, which was already proven, the first mode of transmission was said to be droplet, and lots of paper being published in very reputed journals telling that it is airborne transmission. Now, when it comes to airborne, it is present everywhere in the air. So you have to take certain control measures. So if it is spread by droplets, what are we supposed to do? So very known measures, I will say, but I am emphasizing again. So first is reducing the direct contact with the person who is infected by COVID-19. Then kids generally don't stay in one place. They try to touch things. So try to keep the surfaces clean, which have come in contact with the droplets of infected person. You have to keep the physical barriers and proper physical distancing of these kids with the people who are COVID positive. Especially, it becomes difficult when the parents are positive and the kid is negative. So the barriers become difficult. So you have to take into consideration the home isolation policies. And last, which is the most important one, we call it as COVID behavior. That is use of masks and proper respiratory hygiene. Whoever is positive has to use a separate basin, a sink, or toilet for that matter. And use of mask is a must. You should not stop using the mask even if the cases or number of cases are coming down. And what you should do when it is airborne, you should you should stay in a place where it is adequately ventilated. If you have air filters, if you have a equipment to filter your air, you should do that. You should reduce the crowding, as it was very nicely said in the previous thing, that you should avoid crowds. It is not wise to go in the crowds, because if you go in crowds, you tend to spread it very fast. Using masks. Now, when talking about the children, you should pay a very minor attention to their fit and quality. The mask should be properly fit on the nose with a metal strap, and it should cover your nose and mouth, and there should be no leak. So especially in children, you should be very attentive to this quality and the fit. And if you are staying somewhere where you have lots of COVID-19 cases around, it is advisable to have an N95 with filters or without filters for that matter. And if the kids are from the families who are having healthcare workers or frontline warriors, they should have a higher grade of protection, higher isolation strategies, a good mask, a good hand hygiene, and a good social distancing norm. So these guidelines are not new. They are emphasized, re-emphasized again and again through various modes. And I'm re-emphasizing them again. Now, for kids, tests to be done to be sure that they have COVID-19 remains to be polymerase chain reaction, that is PCR, which is RT-PCR. CB-NAT is from a few, it is similar to RT-PCR given by expert and TrueNAT. If available, it is a good confirmatory test. Mediated detection CRISPR is another confirmatory test which is available. Loop-mediated isothermal amplification of the virus through oropharyngeal swab can be possible, but it requires exhaustive equipment and time. And then we have rapid tests, antigen antibody detection. When you go for this test, you have to remember that they are point of care tests. They are not confirmatory tests. You have to go for PCR after that. And these rapid tests are not something you will confirm COVID-19 in case of acute diseases or any kid who is showing you any type of symptom of COVID-19. So they are point of care tests. They are not confirmatory. And for all these, you might require a specimen. So what kind of a specimen you require is a nasopharyngeal and oropharyngeal swab, which is the most common specimen studied. Then bronchoalveolar lavage, that is BAL, it was studied for the severe cases. They had taken that also as specimen. Sputum can be considered as one of the specimen, and saliva, I have put a question mark because the studies are still going on whether saliva could or could not be a good specimen. So most common specimen is nasopharyngeal and oropharyngeal swab, and these are the tests you should perform to confirm the COVID-19. Rapid tests being point of care tests. Talking about the incubation period of how long this virus stays in the body or how far you should quarantine yourself. Most of the studies have told it is same as that of adult patients, that is 5 to 14 days. Fewer studies have reported the incubation period to be 2 to 10 days, taken all the reasons why kids can show a shorter incubation period. So that is what we will take, but what we are following is 5 to 14 days of incubation period. And in kids, there are 3 major phenotypes. There are pre-symptomatic kids, there are asymptomatic, and they are symptomatic. What do I mean by pre-symptomatic? That is a phase from where they got exposed to the virus and the time till they show you the symptoms. So those are called as pre-symptomatics. The kids are called as asymptomatic when your PCR is positive, but they do not show you any symptom which are related to COVID-19. And then are the symptomatics where the test is also positive and they show to you the symptoms. Now, when you have the symptomatic phenotype, what are the symptoms? We'll see. So we tell it as clinical presentation, and you will get a classical presentation, like classic COVID-19 signs, or you will get something called as atypical presentation, which is less common. So these classical presentations are fever, cough, cold, sore throat, shortness of breath, fatigue, loss of smell test, muscle pain, that is myalgia, and runny nose, that is rhinorrhea. So this spectrum is very, very vague. It is same as that of the flu, but it is classic to any respiratory virus. So is it for COVID-19. So these are the symptoms which you will get in a kid who is symptomatic. So do not neglect if they show you any of these at any given point of time. Even if they don't show you all, if they show you any 1 or 2, do report it to the medical facility. And along with this, if they show this atypical presentation, that is surely not to be neglected. Atypical presentations are in form of GI manifestations, like the gastrointestinal manifestation, which occurs in 5 to 10% of the kids in form of either diarrhea, vomiting, or abdominal pain. Certain cutaneous manifestation like the nail beds and all. And the majority symptom is COVID toes, which looks like this. So you will have reddening below your cutanic bed. So that is a very classic sign of COVID, and it is atypical. It occurs in less than 3%. And of course, the multi-inflammatory, multi-system inflammatory syndrome of children, that is MISC, which occurs in less than 1%, but it is the most severe form of clinical presentation you will get in the kids. So these are the signs and symptoms you are going to see in the kids with positive COVID-19. Now moving on to if I get these symptoms, or even if I don't get these symptoms, how do I assess the severity of it? So severity is assessed based on the symptoms they show you, and the treatment is basically based on the grade of severity. So assessment is based on the three. You classify this severity into mild, moderate, and severe. So when you tell the kid has COVID-19 under mild disease, what do we get there? You get a fever, you get sore throat, you get runny nose, cough, diarrhea, vomiting, and you don't get any fast breathing. It is and, it is not or, it is and. So it is a definite parameter where you will consider them in mild. So along with these symptoms, you will not get any tachypnea or fast breathing, which is age based. So those are the kids which you will tell them as mild. You will tell kids as moderate when they have fast breathing. So first one is your tachypnea. So how do we define this fast breathing? For any baby who is less than 2 months, respiratory rate of more than 60 per minute is tachypnea. For any baby who is 2 months to 1 year of age, more than 50 respiratory rate is tachypnea. 1 to 5 years of child showing you a respiratory rate of more than 40 per minute is tachypnea. And anybody who is more than 5 years breathing at a rate of more than 30 calls it as a tachypnea. So this is a very important parameter when you consider moderate disease. Or it might not be only tachypnea, or you will have presence of hypoxia, which we define as SpO2 of 90 to 94% on room air, that is your oxygen saturation. And there are no signs of severe disease, especially pneumonia. So pneumonia, you will have to do chest imaging, you will have to do arterial blood gas to know whether there are any signs of pneumonia. So moderate has to not have any mnemonic signs, but it will be defined based on either tachypnea or hypoxia, where the kid will have SpO2 of 90 to 94% on 21% oxygen, that is room air. When we consider it as severe disease, first one will be pneumonia. So they will have pneumonic patches in their lung, they will have breathing difficulty because of it. And if they have saturation of less than 90, they have tachypnea, they have grunting, that is a sign of severe respiratory distress, and severe retractions or indrawings of the inspiratory respiratory muscles. So these are the basic signs when you will tell that the person has severe COVID-19. Then if they have lethargy, they have seizures, they have somnolence, they are not in a state of their well-being, they are either too droopy, they are either too active, or they are not oriented to the name, place, and time. If they show severe GI spectrum with severe diarrhea, vomiting, and abdominal pain, which is severe, so that is also considered in the severe spectrum. And if they have critical disease, which is a subset of severe disease, then they present you with ARDS, that is acute respiratory distress syndrome, or shock, or multi-organ dysfunction, or thrombosis in the known cases of coagulation problems. So this is how you will classify kids into three categories, that is mild, moderate, and severe. And we'll be seeing the treatment based on the same severity score or severity classification. So we'll go into the management quickly. So if they have mild disease and they are asymptomatic, if they are without any comorbidities, you have to treat them at home with self-monitoring. You need not go to a medical facility. And if they are asymptomatic with mild, with comorbidities, you have to hospitalize if there is no healthcare access. So even if they are having mild disease, but they have comorbidities, you have to hospitalize them. And in any case of moderate, severe, or critical disease showing all the signs which I have said in critical spectrum, you have to surely hospitalize them. Do not neglect those symptoms. They are ill, so you have to hospitalize them. So these are basics. So what will you do when you have mild symptoms and you denote it as mild disease? So after diagnosis, so you have confirmed that it is COVID-19, you need not go for any additional investigations. You need not prick them for blood, or you do not need to run any investigations. They are just mild spectrum disease people. You have to monitor temperature. So a basic requirement, you have a thermometer in your home, either mercury one or a digital one. That doesn't make any difference. You should have a thermometer. And if possible, if you have an co-oximetry or SpO2 monitoring, it is very good. So you should have, especially if you are a healthcare worker, if you have kids around, or if you have so many cases around you and you want to monitor your child, you should have a SpO2 monitoring device, that is a small pulse oximeter. And with that, you have to watch for danger signs, which might occur in the mild disease state if they are worsening to the stage 2 of pathophysiology. So what are these danger signs? First one is fever. Even if mild disease comes with fever, if the fever is consistently high grade, that is more than 102 degree Fahrenheit, which is more than 4 to 5 days, you definitely have to consult the medical facility. Then your kid is showing rapid breathing, which is not something mild. Kid is not taking oral intake, a loss of appetite like situations. They're very lethargic or they are very irritable, the extreme spectrums. Cyanosis, like bluish discoloration of their finger, or nail beds, or lips, or SpO2 less than 94% if you're monitoring that. And then the signs of dehydration, like decreased urine output, dry mucosa, sunken eyes. These are all the things which will lead to dehydration, and that is bad. So if you have any of these, when you're monitoring mild cases, you have to quickly go and contact the medical facility. So what do we do in management of mild? If you have to home isolate them, it's very difficult for the kids to get home isolated, but you have to make sure they get it. You have to give all the supportive care, make them eat properly, make them sleep properly, all that. Rest is required to give adequate hydration and feeding. If they are feverish, you have to give paracetamol 10 to 15 mg per kg per dose, and reassurance and counseling from the medical practitioners would definitely help. So that is what you're going to do when the kid is having mild symptoms. What will you do with a kid who shows you moderate disease with these signs, as I've already said? You will admit, not necessarily in ICU or HDU, you will admit in the primary healthcare or in the ward. Investigations will go as per the requirement. It might be hematology, blood chemistry, you might require a chest radiograph to know there is no pneumonia. It depends, and not necessary in all. It depends on the clinical presentation of that child. You have to monitor all these things which are generally monitored in wards, that is your vitals, heart rate, respiratory rate and temperature, saturation of course, and the signs of dehydration and overhydration. So in dehydration, you will monitor urine output, the oral intake, and overall hydration status, looking into their skin turgor, a sunkening of the eyes, and whether they are taking good oral intake. And then you will look for overhydration with edema, whether there is excess of fluid which is accumulated in the lower extremities, etc. Then you can think of oxygen here. So moderate diseases where you will give oxygen if they are not able to maintain the saturation of more than 94%. And well tolerated oxygen interfaces are nasal cannula and prongs or non-rebreathing masks. So these are the proven interfaces. So I'll be talking about that in the subsequent slides. You can try awake proning because this category is pretty well tolerated, pretty well good. You can tell them, you can instruct them for proning. So proning is sleeping exactly opposite to how you sleep naturally, that is supine. So you go prone, and you can change this position every second hourly. The point is proning is proven to be good in improving the gas exchange or reduce the respiratory distress. And you have to correct the hydration if you see any signs of dehydration, because overall, if the hydration is not maintained properly, it will set up into hypoxia eventually. So either you give oral feeds or you switch them on IV fluids. For fever, again, you can go for paracetamol, 10 to 15 mg per kg. For any wheezing or any known cases of childhood asthma or asthma, inhaled bronchodilators are good. MDI with spacer is the preferred equipment than the nebulization because the aerosolization is the problem. As far as antibiotics are concerned, you should not give any empirical antibiotics unless you suspect a bacterial infection. If the deterioration of hypoxia is very bad in moderate category, you have to consider systemic steroids like dexamethasone or hydrocortisone. And do not delay referring to higher center. Then you get signs of increased work of breathing, any hemodynamic instability, and increase in oxygen requirement. And if you do not have proper equipment to give oxygen therapy on an escalated level, so quickly shift to the higher center. So that is what you're going to do for moderate disease. Moving on to severe disease, you will have to admit in ICU or high dependency unit because they'll be very ill. Basically, they'll have pneumonia, which may lead to ARDS, shock, or any other multi-organ failure. So you will have to have a good monitoring. In investigations, ICU investigations, you're going to evaluate for any thrombosis, which is causing this, any other organ or failure. You're going to run blood gases to see the gas exchange or acid-base balances. Going to do a chest imaging or chest radiograph or a MRI or CT, and you have to get an ECG. These are the investigations which are normally done in ICU. And you're going to monitor the same vitals, SpO2, and hydration. Then here you're going to start on with steroids, which are either only for respiratory system or systemic. Here the role of remdesivir was highly recommended. Not in mild and moderate. Remdesivir can be used only in the severe disease. And you can move on to the empiric antibiotics taken the septic problems. And you have to restrict the fluid because restrict the fluid by properly calculating the fluid intake, and you can support the organ if they are failing. For example, if the kid is a known case of chronic liver disease or chronic kidney disease, you are going to support it with renal replacement therapy or dialysis. And the measure is supplemental oxygen. They are sick, they will need oxygen. So what are the different ways you can provide oxygen to these kids? First one is you will require supplemental oxygen in any kid who is not maintaining SpO2 more than 94% during resuscitation, where you have just seen them and they're bad. Or in stable recovering children, you can expect SpO2 to be 90%. And if they are not maintaining that, go for oxygen therapy. What are the better tolerated interfaces? Nasal prongs and cannula. Kids, they will not tolerate a mask or a NIV nasal mask or oronasal mask. So better are these. And interfaces to decrease the aerosolization. So when you put up a nasal prong, it's wise enough to use a surgical mask or an oxygen hood over that, so that whatever aerosols are produced do not get spread. So that is a wise technique. And even if with prongs you're not able to maintain an SpO2 in the range, you can consider these following therapies. One is face mask with flow of more than 5 liters, which is giving you 40 to 60% of FiO2. Oxygen hood more than 5 liters might give you 30 to 90% of FiO2. Venturi mask with fixed FiO2 of 28 to 60%, and NRBM with flow of 10 to 15, which gives you 80 to 90% of FiO2. So this you can consider if nasal prongs and cannula is not working for you. Next, amazing therapy which is widely studied in pediatric population is HFNC. We also call it as HHH-FNC, that is heated, humidified, high flow nasal cannula. And it is a preferred choice over CPAP or BiPAP because it is first well tolerated and it is easy to assemble as well. So you can start with 0.5 to 1 liters per kg and you can increase to 2 liters. So for example, if you have a 10 kg kid, you're going to start with 5 liters of the flow, slowly escalating it to 10 liters and then 20 liters. So that's how you should escalate the flow of HFNC. Target should be 90 to 94% of saturation with monitoring of the heart rate and respiratory rate. Yes, and you have to monitor them for 1 or 2 hours. And if this doesn't help, you have to quickly escalate to either NIV or invasive mechanical ventilation. Again, a 3-ply mask, that is your surgical mask, which can cover the nose and mouth of the child, is wise enough to use with HFNC as well to reduce the aerosolization. Moving on to the another therapy, that is your non-invasive ventilation or CPAP. The major thing why we don't use CPAP or we don't waste time using NIV in kids because they will not tolerate. And you all know that if you don't fix the mask properly, it will leak and you are not going to achieve anything. So that's the main reason why not many studies have shown that NIV is a good oxygen therapy way or non-invasive ventilation to give it to kids. So if you are planning, avoid using the single limb circuits or vented mask for the risk of aerosolization. You have to have a filter, either bacterial or viral, at your exhalation port. Whole point of NIV is PEEP, so you have to give a proper amount of PEEP to reach your saturation targets, and mostly monitor them throughout. And if you see that they are not able to tolerate it and there are no improvements, do not waste time to escalate and go for intubation. So that is what is required. So NIV is not preferred in kids because of its less tolerance. And the next spectrum is the very favorite topic of RTs is acute respiratory distress syndrome in pediatrics. So you have to classify this based on something called as PALIC definition. This is same way how you define Berlin definition in adults. For pediatrics, you have PALIC definition. So you can Google it, you can read about it. There are criteria based on chest imaging, based on your oxygen saturation index. And that is how you will classify ARDS into mild, moderate, and severe. So once you are done classifying that, you are going to supplement the oxygen if they are not able to maintain the saturation of more than 90%. So that's when you will start oxygen. Now, how will you start? So if your oxygen therapy devices are not helping, you can escalate to any of these. CPAP, NIV, HFNC. And when you escalate to intubation and mechanical ventilation, what you should follow is the lung protective strategy. So you all know that in any given ARDS, you go for this strategy: low tidal volume with 4 to 6 ml per kg, peak pressures of less than 28 to 30 centimeters. Mean airway pressure should stay between 18 to 20 with driving pressures of less than 15. PEEP of 6 to 10 centimeters, even higher in severe ARDS, as that is the strategy. FiO2 should be titrated less than 60 unless required. And you can go for sedatives and analgesics, general combinations of maybe morphine, midaz, or midazolam, fentanyl, like that, plus or minus your neuromuscular blockage. It is on the hospital protocols how you will manage. So this is the strategy you're going to use. And you can consider awake proning if you have mild to moderate ARDS. You have to use a cuffed endotracheal tube with an inline suction, mostly the heat moisture exchanger as humidification device, and use inline nebulizer than MDIs if you're giving any nebulizer. This is all to avoid frequent disconnections, because ARDS people are sick. You should not disconnect the artificial ventilation quite often. You have to restrict the fluid so that you can dry up the lung. Even if trying all of this, it is refractory, you are not able to achieve your hypoxia targets, you are going to switch to non-conventional modes like HFOV or ECMO or prone positioning, which are proven rescue strategies for ARDS. And as a RT, you should daily assess whether I can wean them or I can extubate them. So that attempt should be always there. And the last thing, which I'll be quickly summarizing, is the most severe form of syndrome which is associated with COVID-19 in the kids is MISC, or multi-system inflammatory syndrome. It was reported in UK, and it happens to be very uncommon, that is less than 1%. And you are going to suspect this in any child who is showing you fever more than 3 days, especially with atypical signs, which I have already told. And before considering MISC, you have to rule out any other infection, and you should consider this as medical emergency. So this is a definition by WHO, what is MISC. I'll be quickly summarizing it. It tells that it happens in 0 to 19 years of year-old child with fever more than 3 days. It should have any of these two signs, either rash or any cutaneous manifestation, maybe shock, any cardiac problems, any coagulopathy problems, or any GI problems, any two of these. And they should have signs of infection, that is elevated ESR or CRP or procalcitonin, and they should have no other obvious reason for this inflammation, and they should be COVID-19 positive. Yes, so these are the guidelines or definition, I will say, for MSC. Will you evaluate? So if you have all these things happening in the kid and you are suspecting MISC, so you will see whether there are any life-threatening manifestation like shock or ARDS. If they are there, you are going to run these two tests. So basically, tier 1 is a normal blood profile, and tier 2 will be the specific profiles for cardiac or for sepsis or for any other infection. So you're going to run these two tiers. And if they don't show any life-threatening cause, you are going to run just basic blood profile. And if they don't present you with all this, you are going to evaluate for any alternate diagnosis, and you are going to monitor for the features of MS. And treatment with life-threatening diseases like ARDS or shock, you are going to give a shot of steroid, methylprednisolone, 1 to 2 mg per kg, and your IVIG, that is IV immunoglobulins, which is the most important treatment with antimicrobials. And you are going to evaluate for any other infection which is causing this. If MIS is not because of any life-threatening condition, you are going to evaluate for any other diagnosis, and you are going to start them on steroid, and you are going to start them on immunoglobulins. And you have to keep in mind that if they are known case of any cardiac disease, do not give something called as aspirin to them. Yes, and if they have a cardiac disease, you're going to run cardiac related things like ECG or a cardiac CT for that matter. So basic thing is you have to nullify all the other causes before you term them as MISC, because it is very uncommon. So to summarize my talk, I made it very short because it is a very big topic. Just to summarize, children are can be managed at home if they are asymptomatic, or even if they are mild category, if they fall in mild category of the disease. Hospitalization would be the must if you see moderate to severe category symptoms. Monitoring is the key because you are going to find out any problem through your SpO2 and temperature. And maintenance of oxygen level is a therapy. So everything is to maintain the oxygen levels. So you have to use a correct oxygen delivery device. You have to escalate the support is required in very rational manner. And medication should not be unnecessarily given. So in mild and moderate, if not for paracetamol, there were no medications. So medications generally come into picture in the severe form of disease. And the last one, MISC, is very severe, but it is associated with COVID-19, and you should know about it when you talk about children. And it is, though it is uncommon, if you are finding the features of that, you should be very sure to rule out all the other causes, and then you diagnose the MISC. So that's all from my side for today in COVID-19 in pediatrics, and I thank you all for the patient listening. Thank you.
Thank you, Mrudula. That was a brilliant, excellent talk. I understand that you cannot, it's very hard to put everything together in 40 minutes. We should have a separate day where we just talk about pediatric COVID. But you have extremely nicely explained it very well, everything very to the point and crisp. I know there are a lot of aspects that you probably couldn't talk about, but nevertheless, this is a great introduction for everyone. So I thank you for joining us, and I thank you for making such a great presentation.
Thank you.
Unfortunately, now because we have short the time by about
Yes.
15 minutes, all the speakers went beyond their time. We won't be able to take any questions, though there are a couple of questions in the chat box, as well as a couple of comments from one of our senior RTs. So we can go and maybe have answer those questions back there. So let me thank you again, Mridula. I will thank Ashish. Special mention to Ashish. Despite having a medical emergency at home, he still decided to go ahead and help us with delivering this lecture. So Ashish, special thank you to you. We are very sorry for the loss that you have had in your family, but we are extremely grateful that you joined us today. Let me thank Jitin. Jitin, without you, we won't be able to run this whole show. So Jitin was the brainchild of the whole webinar series. So thank you, Jitin, for helping us put everything together. And lastly, I would like to thank Fisher Packel for sponsoring and supporting the 3-day webinar series. So this brings our 3-day webinar series to the end. We have a lot of activities planned in the coming months. We will keep you updated. We hope that you join us again in the future and listen to us, and maybe be part of our faculty pool. We are always looking for it. So thank you so much. Have a great day, and enjoy your evening with your family. Bye bye.
Thank you. Bye.